honestly still studying, so like I put my book down for a minute and like get up and do some things back to it. And then like I don't know study, I just try to stay awake and study. And then I didn't go to bed till like 3 o'clock this morning. It was rough. An elevator with that person.
Wow.
Can you tell me where that I is on that study dog when it's over rotating?
Step on the elevator, do you see?
Alright.
I think I got it figured out. But
That's just how we
posterior oblique, you see the downside.
If anything happens
Is that
and
right?
anybody gets stuck anywhere, you just
Alright, even on this.
Your boyfriend's family.
Oh, I know. Harry was like, oh my god. He's like, who's that girl you have class with? I was like, that's Tiffany. He goes, oh my god, she told me.
Hello, this is Southwest. Can you all hear us?
Yes, sir.
I was like, oh my god.
Good morning.
That was the first thing. Don't now.
Hello.
I saw you and I see you. Background. But those questions.
Southwest, can you hear us?
Everybody. That hot dog one.
Withful, can you hear me?
Yes.
Okay. I see you guys.
They were great girls.
Virginia Highlands. Donna, I cannot hear you or see you. Southwest, can you hear me?
I bet you got it.
Jason, are you in the classroom this morning?
I am.
Donna's texting me. Would you mind to get a hold of somebody there? They're connected. She can hear other people, but she can't see anybody. And she is talking. I can't see or hear her at all.
So she can hear, but she can't see.
Correct. And I've not heard or seen her at all.
What's the matter? So weird.
And apparently Southwest cannot hear us either.
Josh. I responded to it. That might be why. Not me. I have $1. No, I don't. Billy,
They cannot hear us. I text her. And
Oh wait, Donna, there you are.
hey, do you see us?
You forgot to turn
I
them
do now.
Okay. What about the vision? That would be them.
on. Probably.
Okay.
Maybe.
Hey, so you can hear us. Adam helped me on that because I'm a newbie over here. So.
Okay.
played on the
Can you
microphone.
see anything yet?
No, can't see a thing.
Okay.
Are you teaching from here?
Christy's teaching from Mount
Okay,
Empire.
great.
So, yeah. So, but, can Southwest see?
I've not seen Southwest. I heard them, and I've responded to them, but I've not heard them since.
Okay.
Waiting on
So I'm assuming they can't
No, that's pretty.
hear me.
waiting on.
See, at Southwest, I don't have to push nothing, so I'm on.
So Southwest can't hear.
Waiting on who else?
I'm assuming not because I heard them speak a moment ago. I responded, but I did not hear anything else from them, and I've not seen them since I've been in the classroom.
Can Donna see us now?
She can hear us, but not see us. And I can see her and hear her now, but she can't.
Hey, Christy, we can see on one monitor, but not the other monitor, so.
You're good.
Yeah, oh, right there it is. It come up, yeah. We can see you now.
Okay.
You
I
switched
see-
from us to you.
Yeah.
Yeah. Adam
So,
fixed it.
Donna, you're good?
We're good.
Right.
I see Southwest at the moment.
I see a computer screen. Donna, is that you?
No, that's not us.
Hey, there.
Yeah.
That's Whipple.
Yeah.
Hey.
We see Wistful at the moment.
Okay. Southwest, can you hear me? Can you see me?
All right, thank you.
You're welcome. If you see that, push it.
Okay.
It'll go away.
All right, thank you. Push the blue. All right. I appreciate you coming down. Hope it wasn't a long journey. Okay.
Donna, would you mind to give Southwest Classroom a call?
I'll do it.
Okay.
So I have hands in the car. Like, where's the combo? Like, as I'm leaving out the door. They're like, I have to have my combo. I get there. I locked my combo in the box.
All right, pick it up.
All right, I just text them.
I think they're just muted on Southwest. He forced the camera to them.
I'm here with my baby daddy.
So we're thinking it's just muted, Christy.
Okay, Donna's sent him a message.
Yeah, I'm messaging them.
Okay. Yeah, we could see him talking, but we couldn't hear him.
Brett was there. I thought he had it fixed, but
I am. Are you at Southwest? Okay, I've seen them and I've heard them, but they apparently can't hear me. Okay. 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 Everybody else seems to be connected fine.
Christy, are you talking to Brett?
I'm talking to Dawn.
Okay, because Brett is in the classroom, but they say that they just can't hear. Evidently, he's working on it.
Somebody's there helping you. I'm gathering. Okay.
So just keep on talking and we'll, now, can you hear us right now?
I see your classroom.
You don't hear us at all.
I hear the students talking, but I don't hear you at all, except through the phone.
How about now?
You're very faint. Yeah. Vaguely, but yeah. Yes. The other campuses are fine.
Okay.
Really?
Keep it on handy, I might call you back.
Okay. Okay, Mr. Lowe is there, and they are working on Southwest. So in the meantime, Donna, do you have everybody there?
I reset
Kelly's not here yet.
The only contact where I went to my boss lost it. And I'm like,
Well, she says that she can hear us, but,
there's nothing coming back.
Jason, do you have everybody on your campus?
I have everyone except for Aaron.
Christy, have your class wave their hands if they can hear me. Okay, thank you.
Yeah, you're very low. Can't hear me. I don't know why.
I guess. All Joe. Because I mean, I reset the audio.
This has been going on the entire semester. Can we get it?
Last time they come in, they were having an issue when they were setting Cisco routes. You reset Cisco, that could devolve into other parts. So I'm gonna call Joe and ask him, to get permission whether or not. Hey Joe, how you doing? I'm over here at R206, and we're having sound problems. We can send sound out, our class is talking to others, however, we can't receive any sound from any of the other sides. So far, checked the panel, I cycled the sound options, changed modes on the touch panel, see if that would trigger it, it didn't work, and then after that, I went down to the media place and I reset it, and brought it back up, and I'm still not getting it.
Did you get that link to?
Because when I went to pull it up, it showed that was not on there.
Did you try the other one?
I can't get that extra one that you made to work. That collaborate.
It's
My internet didn't work. My internet on my laptop, I don't understand. It'll go in and out. It's not in here, but it's like fine at my house and stuff. Which I don't understand. Something about the proxy.
setting. Label that as a public network. Connected. Yes, sir. No, no, sir. No, sir, I didn't do anything. Okay, hold on just a second. Whitful, have you all heard Southwest? Have you heard Mr. Lowe? Have you heard their students?
I've heard Don, but I can't tell if that's through the phone or through the speaker. Did you have him on the phone?
But it wasn't a speakerphone.
Oh, Joe.
Okay, I did hear him. Very.
He said he heard you.
Very slight.
Virginia Highland, Donna, have you heard them?
Just when he was speaking earlier, and it was very faint.
Yes, they've heard you, but it's faint.
Okay. Highlands just appeared. Tell him to ask them to
Virginia Highlands, would you guys be quiet just a minute? And Withful, will you make some noise? So let's see if it will switch to you.
Yes, can you hear us?
I can.
Can you see us?
Oh, keep talking.
Okay, I see Southwest right now.
Did you see them, Mr. Lee?
And
What was that, Joe?
I could see Southwest for a minute, but I couldn't tell if that was them talking or not. Did we ever switch over?
I don't think so. Not on their campus anyway. You did on mine, but I don't think on theirs. Me? You want to see if it switches back to me? Okay. Good morning. Bless your heart. There's issues there, isn't there? Yes, they are. I agree. I've lost way too much class time.
Let's see. Well, right now, I got it kicked up pretty close.
Okay, thank you.
To max, probably. Okay.
Kayla, depending on your and your version of Windows,
Right now, we're at 50%.
how you're holding your mouth. I mean, it may ask you questions when you go into it the first time to allow run and give whatever permissions that it asks, because it asks different things depending on what software that you have. And it'll take a while. It'll have to actually install Collaborate, and it'll take just a little while to do that. No. After you've clicked on the link, right? After it loads, it will automatically come up.
Turn it up, okay. Yeah, we got sound. We got sound coming through the instructor's line.
Oh, like that one. Favorite. Mine are my favorite.
What are you talking about? Those little suckers?
Well, no. Cream soda's my favorite. Little suckers.
No, thank you.
Blue raspberry.
So far, no one's tried to reconnect yet.
I was talking about like in general. Well, I don't like or Apple.
Right, we're on.
I can't. You like pickles. I made my oh boy, this is day after after you have that, and one of him eat. You're not supposed to eat the paper. It's like spit out. But mom, it's my paper too. That's how I'm going out. Spit it out.
I literally, when I read that, I laughed I laughed out loud. I literally.
He had chewed it up into a ball. That's nasty.
Okay, so we should be getting, we're not getting audio or video on the Southwest campus.
Dave? Are we doing?
No, I don't have it.
What is it? Christy, it's pulled the Blackboard Collaborate, but I don't know where to go from here.
Southwest, I see you. Can you hear me?
I got it.
Southwest, I saw you had left and came back. I see you. You can't hear me. Can I just bang my head against the desk? Will that help?
Christy, can you hear me?
Yes.
Can you capture the camera back?
Can you hear us at all, Mr. Lowe? Hello? Southwest? Can you hear us? I'm guessing that's a no. Especially since he's calling me. I'm guessing you can't hear us.
Well, we can't see or hear you or I'm going to suggest that you're being paid. Go ahead with your class, and we'll continue to work here and
Okay.
send these folks.
Okay. I can hear you all and I can see you all.
Okay, we'll mute our mic so we don't interrupt you.
Okay.
Until we can get video.
Hey, Joe.
When it appears that we're connected back, we'll talk to you.
Okay. All right. Thanks. Those of you that were in here when it connected initially, did you hear Polycom come on? Hey, were you all in here when it connected the first time? Yeah. Did Polycom come on? Yeah. Okay. All right. Good. All right. Well, I'm going to make sure that everybody else can still hear and see us. Virginia Highlands, can you still hear and see us?
Yes.
All right. Withful, can you still hear and see us?
We're still good.
Awesome. Okay. Well, I'm gonna continue with class, and assuming the recording works, and we will send it to them. They are continuing to work on their campus to try to fix whatever the problem is. Okay. I've had a couple questions about oblique lumbar spines and how to tell when they are rotated correctly, when they're over-rotated, and when they're under-rotated. These 3 slides that are in your PowerPoint aren't necessarily in your textbook, but this will help you understand how to gauge if this is a correctly rotated oblique. And don't get too extremely bogged down about this right now. Yes, you do need to know what the parts of the Scotty dog are. You do need to know the specifics of the positioning of the oblique lumbar spine. And you do need to, in a nutshell, at least be able to say, yes, this is good, and no, it's not.
Christy just dropped off.
No, I haven't rebooted the system.
went back to go see a college at Christmas.
Everybody's getting checked out.
I love them. I just hate being like, you know, like one of those stories. I paid $25 or $30 for a t-shirt, and I'm like, oh wait,
Hey, no. Right. We just lost Mountain Empire.
what did you send her? Oh, that's usually what I send. That's funny. Okay, I'll let you know.
Okay. Okay. Sorry. I thought we had it figured out.
She'd cover that stuff up so that I couldn't find it.
Yeah, they just dropped it. Oh, if we just shut everything down and drive back, would that help?
Wonderful. I see you guys. Please tell me you can see and hear me.
Yes.
Awesome. Virginia
We got
Highlands.
you too.
Right now.
Awesome. Southwest by chance.
All right. Thank you, Don. Okay. Bye.
By chance. Southwest. Can you hear it? No. Okay. Moving right along. Okay.
Okay.
For the oblique lumbar spine.
That was, John, he called Kim having. Yeah.
Another thing that may help you also is if you all decide to take the elective critique class next fall. I think Miss Donna will be teaching that. Is that correct?
What did you say I'd be teaching?
Critique?
Yes, yes, yes.
Miss Donna will be teaching critique next fall, and it's an elective class. You don't have to take it, but it will help you tremendously. It will do a couple things. One, it will reinforce positioning concepts, because by the time that you hit next fall, it's been a year since you've looked at specifics of abdomen, specifics of chest, specifics of upper extremity. So it will reinforce those positioning concepts, but it will also help you in the clinical setting, because by the time you get to fall semester, you've been in clinicals 5 weeks, and you've already seen a few things that you are having trouble with all the time. Like, for example, lateral knees. You know, I every time I do a lateral knee, I have to repeat it. What am I doing wrong? And critique will help you with that. Critique will help you be able to look at an image like an oblique lumbar spine and know better, is it over-rotated or under-rotated, and how can I fix it? You will learn some of these tricks of the trade when you get in the clinicals. You will. Other techs experienced techs will be wonderful at helping you with this. But the critique class, if you decide to take it, will help you a lot as well. So if you decide to take critique, it will help you with this too. But looking at oblique lumbar spines, for a correctly positioned oblique lumbar spine, which is overall 45 degrees, you're going to see Scotty dogs all the way down. The zygapophyseal joints aren't seen, and they're open, and that's between the leg and the ear. So all the way down, you see that joint space open. The pedicles, which is the eye of the Scotty dog, are halfway between the midpoint of the vertebral bodies and the lateral border of the vertebral bodies. So right here would be the middle of the vertebral body, and right here's the lateral border of the vertebral body, and the eye is right in the middle. And you definitely see that this is a dog. This is a Scotty dog. They're well defined. Are under rotated, like this one, you still will see zygapophyseal joints. but they won't be as open. They will appear closed. Look at this one. This one, you don't see the distinct line between the leg and the ear. So the zygapophyseal joints are closed. You still see Scotty dogs somewhat, not as well as a correctly positioned oblique. But the eye, the pedicle, is closer. If it's under-rotated, the pedicle is closer to the lateral border of the vertebral body. So the eye is all the way over closer to the edge. You see more of the lamina, so you see more of the body of the Scotty dog. That's under rotation. So under rotation, the eye is over closer to the lateral side of the vertebral body. And the lateral side is the eye, whichever way the dog is looking toward. Okay, so the eye is over closer to the side of whichever way the patient is obliqued to, on a posterior oblique. If they're over-rotated, it's just the opposite.
I turned them off.
You still see Scotty dogs, but they look kind of squished. The zygapophyseal joints can be closed, especially you see this one is closed. This one up here is closed at the bottom. You don't see Scotty dogs hardly at all at the top. And the eye is closer to the middle of the vertebral body. The pedicle is closer to the middle of the vertebral body. So this, you see less of the lamina or the body. So this is how you can tell if it is over-rotated. The eye's in the middle if it's over-rotated. The eye's over next to the edge if it's under-rotated. That's the easiest way to tell. You can also, in some ways, look at the ilium. This is almost AP. Not quite, but almost AP. This is almost lateral. So this one is under-rotated. This one's over-rotated. So that's another way that you can look at it and kind of trying to distinguish. Does that help? Okay, don't forget, if you've not taken it already, your Chapter 9 test is today. It is proctored. So you've got until the end of the day, whenever your testing center is closed, to take that Chapter 9 test, if you've not already taken it. Also, the homework assignments that are for Chapter 8 and 9 combined, which are under the Chapter 8 module folder. And then the homework assignments for Chapter 9 also are due today, but not until 11:55 p.m. tonight. So if you've not done those already, you have until the end of the day to get those in as well. And we're going to start on Chapter 10. Bony thorax, sternum, and ribs. Okay, the bony thorax consists of the sternum anteriorly, that's the breastbone, the 12 thoracic vertebrae posteriorly, 12 pairs of ribs that connect, so to speak, the sternum and the T-spine, and this forms a cage. This cage-like structure protects the lungs, the heart, and the great vessels. The sternum, again, that's your breastbone. Also, it supports the clavicles, provides attachment for the costal cartilages. It's about 6 inches long, approximately. It's a flat bone, curved slightly anteriorly. The top part of the sternum, this little part right here, is the manubrium. It's the widest part, now a couple inches long. The top edge of the manubrium is a curved dip in the center called the jugular notch, also called the suprasternal notch, also called the mandibular notch. Not mandibular notch, manubrial notch. Sorry. This notch can be easily palpated. We've talked about it since the very first chest chapter. It's something you can palpate, and on some patients, it's something you can see. Lies around the level of T2, T3. Just lateral to the jugular notch is where the manubrium and the clavicles articulate, called the sternoclavicular joints. Inferior to that is where the cartilages to the first pair of ribs attach. So these little notches here are where the costal cartilages attach. Every one of these notches are where costal cartilages attach. At the most inferior portion of the manubrium is the sternal angle, and this is where the body of the manubrium body of the sternum joins the manubrium. It's also can be palpated because it protrudes and it's prominent. It lies about the level of T4, T5. And this is where the costal cartilages for the second pair of ribs attach, is right at the sternal angle. The longer portion of the sternum is the body, also called the corpus or the gladiolus. The longest part of the sternum. It's about 4 inches long. The next 5 pairs of costal cartilages attached to the body of the sternum. And the very bottom portion, this tip, is the xiphoid process. We've talked about it before. It lies about T9, T10. In childhood, the xiphoid tip is cartilage, and it ossifies as the children get older. Turns into bone during adulthood. It becomes completely ossified by about the age of 40. The xiphoid process serves as a bony landmark for the upper portion of the liver and the lower border of the heart. You need to know these landmarks. Jugular notch, T2, T3, sternal angle, T4, T5, xiphoid tip, T9, T10, and at about L2, L3 is the inferior rib angle, the inferior angle of the ribs. This is the lowest margin of the ribs. Lies about L2, L3. Now, the lower sternum has a couple of congenital abnormalities that can happen. One is called pectus carinatum. It's also called pigeon chest, where the jugular notch, not the jugular notch, the xiphoid tip, points outward, abnormally points outward. The other one is called pectus excavatum, also called funnel chest. In funnel chest, the xiphoid points inward abnormally. The ribs are numbered from top down, the first pair of ribs, second pair of ribs, and so forth, all the way down through the 12th pair of ribs. The first 7 pair have costal cartilages that attach directly from the anterior border of the rib to the sternum. Ribs 8, 9, and 10 also have cartilages, but those cartilages connects to the 7th rib cartilage, not directly to the sternum. There's also what we call true ribs and false ribs. The ribs come off of the respective vertebra and are numbered accordingly. So the first pair of ribs articulate with T1. Second pair of ribs articulate with T2, and so forth. Ribs 1 through 7 are true ribs. Each have a costal cartilage that connect with the sternum. That leaves 8 through 12 as false ribs, where they don't directly connect with the costal cartilage to the sternum. 11 and 12 don't have those false ribs, don't have costal cartilages at all. They are not connected to the sternum at all. They're called floating ribs. They aren't anteriorly connected to anything. A typical rib, if you take it off of the body and look at it from the top, it looks like this. They vary in breadth and length. The first rib is the shortest and the broadest. They gradually increase from the 1st to the 7th, and then tend to decrease again to the 12th. But they all have the same general characteristics. The vertebral end, or the posterior portion of the rib, has the head of the rib. It articulates with the thoracic vertebral bodies. Right below that is the neck. Right below that is the tubercle of the rib. That tubercle articulates with the thoracic transverse process. Then as it curves forward, there's the angle of the rib. The angle of the rib is where the rib takes that forward turn. It's lateral, and then it takes that forward turn. Then the long portion is called the shaft, or the body, and then the anterior portion is called the sternal end of the rib. Now, if you look at them straight on from a posterior projection, posterior view, so you've taken this rib off of the body and just holding it out as it would sit in the body and looking at it from the back. So this is the vertebral end, and it's what's closer to you. As it goes laterally, it's kind of almost flat straight. But as it gets to the lateral side of the rib and hits the angle of the ribs and makes that forward curve, it also curves downward. And from the vertebral end, the posterior edge, to the sternal end, the anterior edge, there is a difference of 3 to 5 inches from superior to inferior. And that's normal. They curve forward, but they also curve downward. They slant downward. The posterior ribs are higher and more horizontal, or flatter, than the anterior portion of the ribs. Now, on the medial surface of the rib is this groove. It's called the costal groove. This groove houses arteries and nerves and veins. And this is why rib injuries are so painful. Because arteries, veins, and nerves lie right in that groove. And if there is a fracture of a rib, remember, every time you breathe, those ribs move. You inhale, the ribs turn slightly outward to allow the chest to expand. Then when you exhale, they turn back inward. So every time you breathe, if you have a rib injury, you're irritating the stuff that sits right inside that groove as that rib moves slightly to allow you to breathe. Also makes rib injuries pretty dangerous. If it is a bad fracture and can cut an artery, it can make it pretty dangerous. Now here's a picture of the ribs without the sternum and without the costal cartilages. And this is what it looks like. Excuse me. First pair of ribs are the shortest and the widest. They get wider as it goes down to about 7th or 8th rib, which is the widest diameter of the chest, and then it gets smaller again. This one is shaded to blue just to show you how it curves not only anteriorly but downward as well. Any questions about this so far? Okay. Articulations of the bony thorax. The costochondral union or junction, it's what's labeled in A. It's ribs 1 through 10 where the anterior end or the sternal end of the ribs and cartilage attach. These are our synarthrodial types of joints. B is the sternoclavicular joint. They're synovial joints. They permit gliding movements. C is the first rib sternocostal joint that has no movement. D is the 2nd through 7th sternocostal joints. They have a plane or a gliding movement. And then E are what is labeled and what is known as interchondral joints. They are the joints between the costal cartilages themselves. This is posteriorly how they articulate with the thoracic spine. We've talked about this before during the T-spine chapter. The head of the rib articulates with the posterior aspect of the vertebral bodies. That is known as the costovertebral joint. Costo meaning rib, vertebral meaning vertebra. That's the head of the rib. That's the end of the rib. If that's hard for you, if the head of the rib is hard for you to remember, just remember the end of the rib articulates with the vertebral body. It has to be the top. It has to be the head. Then behind the head, you have the neck. Then below that is the tubercle of the rib. It articulates with the transverse process of the thoracic spine. That's known as the costotransverse joint. Here. So the costovertebral joint is where the head of the rib articulates with the vertebral bodies. The costotransverse joint is where the tubercle of the rib articulates with the transverse process of the thoracic spine. They both are synovial joints with diarthrodial gliding movement. They allow for breathing. The ribs move as we breathe. They move up and rotate outward as we inhale. As we exhale, they move down and rotate inward. They also allow for body movement. As you twist your thoracic spine, those ribs have to move with them. There's a chart on the bottom of page 356 that tells you about the joint classifications of the thorax. So here's what a sternum looks like on an image. Sternums are hard to image, but this one is an absolutely beautiful one. A sternum is one of those things you get when you don't need it. And when you need it, you can't get it sometimes. They're difficult because they're so small. They're so thin. This is an RAO sternum. You don't do a straight AP or PA sternum because if you did, it would be superimposed by the spine. And the spine is a much more dense structure, so you don't see the sternum in a straight AP or PA projection. So you have to oblique a patient to see the sternum. But here you see the manubrium. Here's the sternoclavicular joints here, jugular notch. Sternal angle is here, the joint between the manubrium and the body. Here's the body, and it looks jagged. It looks spiky. And that's exactly what it's supposed to look like. Because remember, here, these areas here are where the costal cartilages attach. And then here's the xiphoid tip, the xiphoid process. Now, to see a sternum, we have to oblique the patient to get the spine out of the way. You want to do it You must rotate the patient to get the sternum out of the way of the spine. And the point of the oblique is to rotate the patient in such a way that the sternum is projected over the heart shadow. It creates a more uniform image of the sternum if you rotate the patient so that the sternum and heart shadow are superimposed. So the best way to do that is an RAO. That the RAO puts the sternum over the homogeneous heart shadow and allows you to see that sternum better. So, the amount of rotation varies slightly depending on the patient's chest. If they have a large barrel chest, then you rotate them just a little bit. If they have a very thin chest, then you rotate them more. It's 15 to 20 degrees. It's not a big difference one way or another. But if you rotate a thick patient too much, then you're going to project the sternum over here over the lungs and not over the heart shadow. So the thicker the patient, the more rounded the chest, the less you have to oblique your patient. Because the spine is farther away from the sternum. So you don't have to oblique them as much to move the spine out of the way. I'll bring Harry next time and try to show you somewhat on Elmo. Maybe that'll help make it a little more clear to you. The thin-chested, and think about this, the thin-chested people, the thin thorax, the very small people, the spine and the sternum are closer together in that cage. So you have to rotate that cage more to get that spine out of the way because it's closer together. So the thicker the patient, the more rounded the chest, the less rotation. The thinner the patient, the less rounded the chest, the more rotation. And I know that's confusing. Does anybody have any specific questions about that right now? Okay. Technical considerations for sternum. You do want to use a breathing technique. 3 to 4 seconds is what, or 2 to 3 seconds is what your book recommends. Older books recommend 3 to 4 seconds. Either way, it's a breathing technique. What you want to do is you want to give that heart shadow time to beat and creates a little bit of motion on your image. You want the ribs and the lung markings blurred with breathing so that you can see the sternum, the stationary sternum better. Now, you don't want them to take a huge deep breath because if you do, you're going to move the sternum. But if they take a big, deep inhale, that sternum's going to move too. You just want them to breathe normally. So you don't necessarily give them breathing instructions. You just tell them to hold still and they'll breathe normally. 2 to 3 seconds. And what it does is see how blurry these ribs look? And you see no lung markings at all. Those lung markings are blurred. And the heart shadow is right here. And you don't see any definition in the heart shadow. It's blurred. But the sternum is very crisp. That's what you want to see. You want breathing motion, not patient motion. So they breathe normal, hold still for 2 to 3 seconds for a breathing technique. You want to use a lower kV range. You want to use from 65 to 75 or around 70 kV due to the long exposure time, but also due to the thin sternum. You don't want to use 90, 100 kV on this because you will overpenetrate that very thin sternum. You want to use a safe SID. 40 inches is what your book recommends, and it specifies never to use an SID less than 38 inches or 15 centimeters, and I'll tell you why. It used to be taught, and you may see some older texts still do this. it used to be taught as a routine. You position the patient for a sternum in an RAO position. Then once you get everything ready, you pull that tube down to where the collimator box almost touches the patient. So you've got a collimator box almost right on top of the patient. Open the collimation up as wide as it'll go and shoot the sternum that way. Now, those images were beautiful. Because what does that because you only had maybe a 20-inch SID, depending on the size of your patient. What did that do to your image? Magnification, exactly. With that low SID, you magnified the sternum, and they were gorgeous. However, also with the lower SID, you've dramatically increased entrance skin exposure. So you've increased the patient dose. So it's no longer recommended that you do that. You keep a safe SID. You keep at least 15 centimeters. So it's 40 inches recommended. And decrease the dose to the patient. You can still get a pretty sternum. But if you see that somebody pull that tube down and put it right up against the patient, don't freak out. It's because they were taught that. That's how it used to be, you know. Lung markings are blurred, and the ribs are blurred, but the sternum is not blurred. The sternum is very clear, crisp. If the patient was moving or taking really deep breaths, or if the patient has labored breathing, you know, they're having a hard time breathing, so they're taking short, choppy breaths, or they're hurting when they're breathing, and it's not a normal breathing situation, then this sternum would also be blurred. Any questions about that? Okay. Ribs above diaphragm. We'll do clicker questions next time. Ribs above diaphragm. Now, this is one of those things that you're going to see slightly differently in practice. So for the purpose of this class and lab and for your test, we're going to tell you what should be done, and we'll tell you why. Doesn't necessarily mean this is exactly what's always done in practice. But ribs above diaphragm should always be done erect if possible. They should always be done on inspiration, and they should use a low kV setting. And the reason is this. For ribs above diaphragm, sometimes these are called upper ribs. When you hear the term upper ribs, it means the ribs above the diaphragm. For the above diaphragm ribs, you want to get as many ribs as possible up against that lung shadow. So you have the patient take a deep inspiration, which will lower the diaphragm. You also do them upright if possible, which will allow gravity to help lower that diaphragm as well. You want to have as many above diaphragm ribs up against that lung so you have that higher contrast of lung, dark lung versus light rib. Now you want a low kV. The ribs aren't very big and surrounded by lung tissue, so use a low kV setting on above diaphragm ribs. You also want to make sure that you lift that patient's chin. If the patient's chin is low, then that chin is going to be, that mandible or even the soft tissue under the chin is going to be superimposed over the first and maybe even the first and second ribs, which will cause you a repeat. So make sure that that chin is elevated as well. So above diaphragm ribs, you want them done upright, you want them done on inspiration, and you want them done with a lower kV range. Then there are those below diaphragm ribs. No matter what you do, no matter if you do them upright and they take the biggest, deepest breath possible, you're still not going to see all 12 ribs above the diaphragm. So we've got to do something a little differently to see those ribs that are below the diaphragm. So below diaphragm ribs are also called lower ribs. Lower ribs, below diaphragm ribs, you want to do them with the patient lying down. You want them to do them with them recumbent. You also want to do them on expiration and a higher KV than the lower. It's a medium KV range, but it's a higher KV than the upper ribs. And this is why. You want to do them on expiration to raise the diaphragm as much as possible. So you see as many ribs as possible below the diaphragm. So you've got a couple of ribs there, maybe ribs 9 and 10, maybe 8 and 9, that you're going to see. Those ribs right there you're going to see against lung tissue on the above diaphragm because you've got done that on inspiration and the diaphragm is lower. Then you're going to see them again against abdominal tissue because you've done them below diaphragm and on expiration where the diaphragm is raised. And that's what you want. So on below diaphragm, you do that on expiration to raise the diaphragm as much as possible. You want to lay the patients down, especially, this is especially true if your patient is large. These below diaphragm ribs, and this is also why you use a medium KV as opposed to a lower KV. These below diaphragm ribs are superimposed over abdominal tissues, which is much more dense. The tissues in the abdomen are much more dense than lung. So you've got to use a higher KV to penetrate that abdominal tissue. The more dense abdominal structures versus lung. But if your patient is large, then what you do by laying the patients down is you let gravity kind of spread out some of that extra tissue. And it'll lay out to the side of the patient, outside of the ribs, instead of over top of the ribs. If you stand a patient up for below diaphragm ribs, and that patient is large and has a large abdominal tissue, or if they're female and they have large breasts, that tissue is going to lay over the lower ribs, and it's going to be hard to see those lower ribs. So lay those patients down for lower ribs, below diaphragm ribs, and let that tissue fall out to the side, not down over your lower ribs. So above diaphragm ribs, do them upright, do them on inspiration with a low KV. Below diaphragm ribs, do them recumbent on expiration with a medium KV. Any questions about that? Okay, this is where ribs get confusing. You may get orders for ribs that are unilateral. So you may do a right ribs, or you may do left ribs. You may do unilateral ribs. You also may get orders for bilateral ribs. So you're going to do right ribs and left ribs both. These are separate exams. Right ribs is separate than left ribs. It's almost like an extremity. If you get an order for right ribs, then that's what you're going to do is right ribs. You're not going to worry about the left side. Typically, if you have a rib injury, it's going to be on one side or the other. Not always. Depends on the injury. But you know, if you fall on your side, you're going to hurt whichever side you fall on, not necessarily the other side. So you've got to get a very good patient history to know how to correctly position your rib patients. Sometimes you're going to do these AP, sometimes you're going to do these PA. Depends on the patient's history. You want to determine if the injury is anterior or if the injury is posterior. You want wherever is injured closest to the image receptor. So if the injury is anterior, you want the anterior surface of the body closest to the image receptor, and you're going to do a PA projection. If the injury is posterior, then you want the posterior surface of the patient closest to the image receptor, and you do an AP projection. So whether you do AP or whether you do PA on ribs totally depends on the patient's injury. Okay, are we good so far? All right. Now, axillary ribs are the ribs, are what we call the ribs on the lateral side of the patient under the armpit. Okay? That's what we call the axillary ribs. Those are difficult to see fractures there in a straight AP or straight PA. So that's why we do obliques also on ribs. You want also, for oblique ribs, you want to rotate the spine away from the area of interest so you can see the articulations a little better between the vertebral end of the ribs and the spine. So you see those a little better on the oblique, but you want to elongate the injury. We'll get more into that in a little bit because that's a little bit confusing, but we'll get more into that. But you oblique the ribs to see axillary ribs, to see vertebral articulation slightly, and you want to elongate the ribs. Marking site of injury. Your book says, and some facilities require you to mark the site of injury. So if a patient says, you know, I fell on a bedpost and I hurt my ribs, well, you're going to ask them where specifically. Well, they're not going to be able to say, well, my 9th rib is where it hurts. But they can point to you and say, right here. You know, some facilities require you to place a little BB marker. It's a little bitty sticker. If you've not seen one already, it's a little bitty round or square sticker, depending on where they buy them from, with about a 2 millimeter BB in the sticker. And you can give it to the patient and say, place this right, put this sticker right where your pain is. And that BB marker will show up on your image and tell the radiologist this is where the patient hurts. So it gives the radiologist and the referring physician a little more idea of exactly where the pain is and exactly where to focus their attention more on when they're looking at the image. Other ways you can do that is by those extra markers that have arrows. Have you seen those extra markers that are just an arrow? If you place an arrow on the side, on your image receptor or on the table or on the outside of the upright bucky pointing at the area of interest, that works as well. Depends on your facility as to what your radiologist wants. Some radiologists want something specifically on the patient. So when you oblique the patient and you rotate the patient, that BB is still on that area of that patient. Other radiologists, however, do not want anything on the patient themselves, because if you place a BB just in the right place, even though those BBs are really small, you could potentially put that BB over top of a fracture. So other radiologists don't want the BB on the patient. They want something on the outside of the patient, but that's on the image, marking the area of interest. So that's where you would use an arrow on the image receptor, but outside of the anatomy. Either one works to point out this is the area of interest. Another thing that you also need to do is to take a really good patient history. Rib fractures are hard to see, so take a really good patient history. What happened? How long ago? Was it today? Was it 2 weeks ago? Do you hurt when you take in a deep breath? Does it hurt when you move? Are you coughing? Are you coughing up anything? Specifically, are you coughing up any blood? Are you short of breath? That kind of thing. Give a good detailed history. That will also help the radiologist know where the site of injury is. And a chest study. Facilities vary on this. But for the, just as with just about anything, but for the purpose of lab and the purpose of class, a PA chest study will also be part of the routine projections for a rib exam. Just like we looked at way back in the early chapter, a PA chest. Just a plain old PA chest. Done exactly the same way as any other PA chest. That's another projection inside of a rib exam. And the reason is this. Sometimes patients with rib injuries also have lung injuries because of those rib injuries. Sometimes a fractured rib can puncture a lung. You may not see that on the rib exam. So that's why you do a PA chest projection with a rib exam. You want to see if they have a pneumothorax. You want to see if they have a hemothorax. And those are going to be seen better on a PA chest x-ray in comparison to a rib x-ray. Any questions on that? Okay, for a sternum, we'll do clicker questions next time, pending everybody gets connected. For a sternum, the routine for a sternum is you're going to do an RAO, and you're going to do a lateral, and that's a rib exam. An RAO sternum and a lateral sternum. These are going to show fractures, inflammatory processes of the sternum, just any pathology of the sternum. You can do these standing up or lying down, either one. If a patient can stand still, remember these are breathing techniques. So these are 2 to 3 second exposures. So if they can stand still that long, it may hurt them less to do this upright than it would to lay them down. Remember, if you've got a sternum injury and you try to lay them down into a recumbent RAO position, you're putting their body weight onto their sternum somewhat. So that may be too painful for them. So if they can do it standing up, it may be less painful for them. You want to use a 10 by 12 inch lengthwise. .40-inch SID, a low MA with a long exposure time to blur those lung markings and rib markings. You're going to rotate the patient 15 to 20 degrees into a right anterior oblique position. You cannot do left anterior oblique for sternum, because if you do a left anterior oblique sternum, it will not place the sternum superimposed over the heart shaft. So you cannot do a left anterior oblique sternum. You do a right anterior oblique sternum. Larger chests require less rotation than smaller chests. So the bigger the chest, the less rotation. The bigger, more rounded the chest, the less rotation. Your central ray is perpendicular to your image receptor and centered to the center of the sternum, midway between the jugular notch and the xiphoid tip. Tell your patient to hold still. And again, if you see somebody that pulls the tube down really, really close to the patient, we don't do that anymore. It dramatically increases patient exposure. And this is what a beautiful sternum looks like. You want to see the entire sternum, including the xiphoid tip, on one image. You want to see the sternum superimposed over the heart shadow here. You want to see heart shadow, lung markings, and ribs blurred, but the sternum very crisp. And this is a beautiful one. You want to make sure that no part of the sternum is clipped. The correct rotation is there. The correct rotation, your spine will be out of the way. And this one's close. There's spine here, but the spine is out of the way. And the sternum is superimposed over heart shadow. If the bone, see how clean and crisp and pointy these edges are? If these edges are eroded, if they appear blunted or eroded, then that can indicate that patient may have osteomyelitis. And that's an infection of the bone and the bone marrow. It can be a possible complication from open heart surgery. So you may do sternums after open heart surgery, a few weeks out, maybe even a couple of months out, looking for those eroded margins, those eroded spikes there that may indicate osteomyelitis. Now for a lateral sternum, you want to do these upright if you can. You want to use a 72-inch SID if you can do this upright. 10 by 12 inch lengthwise. You want to use a longer SID because of the OID between the sternum and the image receptor. You want to make sure the patient's in a good lateral position with no rotation. Your central ray is perpendicular and going right to the mid-sternum where the top of your image receptor is about 1.5 inches above the jugular notch. You want to do this what you want to do with the lateral is you want to have them stick their chest out as much as they can stand it to put that sternum out there as far as possible. So you do that a couple of different ways. You put the patient's arms behind them and have them just stick out their chest. Put their arms behind them, have them pull their shoulders back and stick out their chest. Then you do this on deep inspiration, which will further expand the chest and stick the sternum out. So you put them in a lateral position, pull their arms and shoulders back, push out their chest, and do this on deep inspiration to further expand their chest. Now, if you can't do them standing up, you can do them in a recumbent lateral position. You're not going to get 72 inches because they're laying down on the table, but you still want to, if they can, push their chest out and do this on deep inspiration. If they can't lay on their side, if you're in a trauma situation, they can lay on their back, move their arms up. You can do cross table. And the best you're going to be able to do if the patient's lying supine is just have them take in a really, really deep breath. You can't you can ask them to protrude their chest somewhat if they can. A lot of times they're not going to be able to, and it's not going to be very effective with them laying supine. But you can ask them to take a deep, deep breath to expand the chest. And this is what one looks like. You want to see the entire sternum in a lateral position with no rotation. You don't want to make sure that nothing's clipped, the xiphoid tip is not clipped, the manubrium is not clipped. If you see ribs superimposed over the sternum, then the patient is rotated. If you see lung tissue superimposed over the sternum, then the patient is rotated. This patient is slightly rotated, what you see here. You don't want to see lung markings. You don't want to see ribs superimposed over the sternum in a lateral position. Any questions about, and that's a sternum exam. Any questions on a sternum? Okay, we will start right here next time. Hopefully we will be all connected so we can do some clicker questions next time. Don't forget your Chapter 9 test today if you've not already done it, and all 4 of those homework assignments if you've not already done those. Okay, you guys have a good lab this afternoon. I'll see you on Thursday.
What it is, and I always smell it randomly, but it smells so good.
What was it?
Something smells good. Maybe. Yep, that's it. It smells so good. Every once in a while, I'm just like.
Southwest, by chance, did you guys get connected?
I didn't wear my smoky jacket today, so it's not. My jacket from where I was at the bar the other day. It smells like.
Hey, Christy.
Yes.
This is Aaron. I came in about, I think, 25 or 30 after. Did you get my email by chance?
I saw that you had emailed me, but I did not get to read it.
Okay.
It smells good, doesn't it? It smells like Dr. Pepper.
Thank you for letting me know you're here.
Yes, ma'am. Yes, ma'am.
Hi.
The first time they warned me. The second time. That's good though. Good lesson.
I went through Bluefield State.
Oh, is it pretty big school or ish?
Oh, really?
I like that. I don't hate that at all. It's pretty big school.
I was able to do a lot of it online, so that was a good thing. Yeah.
How long did it take? How long is it?
How long did it take you to do it?
Yeah, after you get
Did you do that after you finished year?
Mm-hmm. Yeah. Yeah, it was in radiography. Kind of getting more toward management and teaching. But yeah, it took. How long did I wait before I went back to do it, or how long did it take to do it?
No, how long did it take your bachelor's after?
I spread it out, so it's more like 3.
Oh, smart.
Yeah. Working 2 jobs, I had to spread it out a little bit. But you can do it at your own pace. That's a good thing about having it set up online like that, most of it. So you can take as long as you need. Of course, they designed that program like that for people who are already working in X-ray. It's designed for that. So.
Have you ever looked into read about seeing her like RAs, like radiological assistants?
RAD assistant, yeah. It's not
real big yet.
It's not big, and the thing is, you'd have to be working somewhere and find someone who will take you on as like an apprentice, sort of. You'd have to find a radiologist that would work with you for clinical, sort of. You know, I think most of the programs require you find someone, but now they may be a little different. Some of the programs they may.
There was a program.
You have to be you have to find a willing radiologist or a few that will work with you.
There's a program that
VCU.
Yeah, I think there's one in VCU. UNC Chapel.
They may have one too.
There's one in our college somewhere.
The only one I know of in Virginia was VCU and Richmond.
I'm talking to
PAs really are.
Right. Well, I was talking to a doctor friend of mine the other day. He said that insurance crap going on. A lot of radiologists or some radiologists have had a hard time like getting reimbursed from like insurance companies and stuff.
I have an IEC that I did last time that we went over, but
Yeah. But there may be a bigger
I know. It's my semester.
For
I'm like,
you
if I find it, I'll give it to you.
use an RA instead of a doctor, you're paying less to do it. But in general, radiologists likely don't really want the RA thing going on, because then it is. You got to think about it. It's for them. It's kind of edging into their territory a little bit. So some may be for it, but a lot of them probably see that as a bad thing for them. Yeah, but that's not really a specialty. There,
I got you.
Eat chicken.
It's pretty.
you
I
can,
know what you're saying.
I had, whenever
but
I went
the
hamburger all the time.
PAs work in a lot of different places, like doctor's offices, mostly either doctor's offices, ER, or
But, so whenever he's gone, I make chicken strips and
Or a
salad
doctor's
At one point.
the other night, and then I had shake and bake chicken legs.
Hard to get into PA school.
It's hard, yeah. Roanoke has a program, Jefferson College, a health and science course. It's expensive.
Okay. We go for some kind of steak whenever I get chicken.
Is it still masters?
I just like chicken.
See, and there's talk about making it a doctorate program. I'm like, if you're gonna do that, why not just go on?
I like steak.
The thing with they're smart. nurse practitioner. Now a lot of those programs are doctorate. Yeah, I'm like, if you're going to go that long, just do the residency, get paid a lot more.
Well done. It's tough a lot of times.
It's hard to do. I kept saying it dry.
I just
But med
tell
school,
them, never know how you're going to get it. Sometimes you get it medium rare, medium well. Sometimes, you know, say medium and I get what I get. So. Yeah.
My sister, you know, she'll order hers and then she'll like always in the back of it. Like she cuts it up and it's got pink in it and she like.
That's exactly what you do.
I don't care.
a lot of things make just as much money,
I don't like it rare.
but a lot of those time and effort into it. I mean, it always takes time and effort, but
My nephew picked it.
it's kind of hard to try to get to the point where you're productive because
I like my burgers.
you get in med school, then you get out, then you're paying,
The order of rare.
you know, you're looking at 8 years.
No.
Yeah.
I think that's like hamburgers.
Minimum of 8 years. Yeah, that's just.
And then your residency.
Once it's ground up, I want it done.
$10, $12 an hour or something.
Well, they're probably, you know, they're probably making about what we would as an X-ray tech, or depending on what they're doing, maybe. Yeah. If you make it about what. But then you still have all the bills to pay. Like you're talking about student debt, $7,000 a semester. But if you go to UVA or
DCOM is last I looked into is 35 a year.
Okay. 25. I talked to Mr. Lowe, and they are still not connected. They're still working on it at Southwest. So get your positioning books back out, at least until they're connected or until class time runs out, whichever comes first. So I'm gonna try and make up some of the class time that I've missed until he gets connected.
Do you want some? Like, and then you can sniff yourself. I just want the smell around all the time.
We may be able to finish this chapter today.
And have another test today.
I'm sorry?
What is the math?
Oh, I'm sorry?
Can you hear me now?
Yes.
Okay. What's the mass for the oblique sternum?
Okay. Depends on the patient, of course.
Yeah.
Your book gives a KV range of around 70. That's what I'm going to say, because analog it says 65 to 75 and digital 70 to 80. I'm going to say about, for an average patient, about 70 kV and about 15 mass, 15 to 20 mass.
Okay. Thank you.
And for a lateral, you're looking at about 75 kV at 72 inches. You're looking at about 50 mass.
50 or 15?
50 for a lateral at 72 inches.
Okay. Thank you.
What was that first math?
15 to 20 on the RAO, and around 50 on a lateral at 72 inches. Of course, that's going to decrease dramatically if you do it at 40 inches. You have to lay them down, but at 72 inches, you're going to look at about 50. Again, those are going to vary based on your patient's size. Okay. I'm sorry, I didn't give those to you when I was talking about them the first time. Okay, a sternoclavicular joint. An SC joint exam is going to include a PA projection and 2 obliques. A PA projection and 2 obliques. What they're looking for on sternoclavicular joints, and this is not an exam, bless you, this is not an exam that is done routinely. It's not done very commonly, but it is still on your list of things you need to know for ARRT. What they're looking for with sternoclavicular joints typically is joint separation from some type of injury. So they're comparing the right SC joint to the left SC joint to see if they're symmetrical, to see if they're the same, and they're going to see if there's any extra widening of the joint, which would indicate separation. So for the PA, you want to use an 8 by 10 inch image receptor crosswise. The smallest image receptor that you have. You want to put your patient in a true PA position. So you want to lay them down, prone. Your book has pillow for head turned to one side, but that's not what you should do for the PA. What you should do is what you see in this picture. Is you should have them, you can give them a sponge under their neck if you want to, or you can just have them extend their neck and put their chin down on the table. But you want them looking straight ahead. You don't want them to turn their head right or left. Even though I know that's what the book says, but that's not what you should do, because when a patient turns their head right or left, it slightly obliques the sternoclavicular joints.
Well, over in Whittle, they're saying that their side's good. And Joe called in, and he actually went in through the system and checked it out.
Southwest, by
and he
chance,
said that
hear me?
Whittle's sending us a high-definition string, which their system.
No, they can't hear me. Okay. So you want to have the patient just looking straight ahead. Of course, you don't want their chin, their nose flat down, their whole face flat down on the table. They wouldn't be able to breathe, and their chin might be superimposed over the SC joints. So you want them to extend that chin out to get it out of the way of the sternoclavicular joints, but also to let them breathe a little better. But you want to have their head straight so that their sternoclavicular joints are not oblique. You're going to use around 70 kV, center cell detector area, and probably about 8 masks.
When does that connect?
Well, Christie is.
Your image receptor, your central ray is going to be perpendicular to your image receptor. Level of about T2 or T3. 3 inches distal to the vertebral prominence.
The way that they report it,
At a 40-inch SID, do it on expiration.
the brain just take
You can also do these with the patient standing up. They don't have to be lying. Do these with these standing up. Just make sure that they're straight PA and that their chin is extended to get their chin out of the way of the sternoclavicular joints. And this is what you want to see. You want to see the medial portion of each clavicle and both sternoclavicular joints. You want to make sure they're not rotated so the SC joint. You're gonna do rotation on this exactly the same way that you did on a PHS. Imagine the middle of the spine, an imaginary line going down the middle of the spine, and the SC joint should be equal distance between that imaginary line to that SC joint and the imaginary line to that SC joint. If they're not symmetrical, then they're rotated. Also want to make sure that these are marked. You want to make sure that your anatomical marker is on this image. Even though it's not on this picture, you want to make sure that your marker is correct on that image. Because in looking at that picture, you have no idea which side's the right joint and which side's the left joint. I'm sorry? You don't necessarily have to mark both, but you can. You can mark both if you want to, but you don't have to, as long as one of them is marked correctly. So if this is the right joint, there needs to be a right marker right over here, or a left marker right over here. But and this is really all you need to see on a PASC joint. I mean, that's all the anatomy you need to see. But by looking at that, you have no way of knowing which side is right and which side is left. So you've got to make sure that you mark these. Now, your obliques are going to be anterior obliques. You're going to do an RAO and an LAO, a right anterior oblique and a left anterior oblique. The LAO is for the left joint. The RAO is for the right joint. The LAO opens the left joint. The RAO opens the right joint. Anterior obliques will best show the joint that's down. So LAO is left joint, opens up the left joint. RAO opens up the right joint. Again, an 8 by 10 inch image receptor crosswise. About 70 kV, about 10 mass. Perpendicular central ray centered to T2, T3, the same centering reference as the PA. Should be also done on expiration. You want to rotate the patient about 15 degrees is all. It's a very 10 to 15 degrees. It's a very narrow, shallow oblique. 10 to 15 degrees. And this is what you want to see. You want to see the medial ends of both clavicles. You want to see the manubrium. And you want to rotate them just enough to move the joints out away from the spine. So here's the open joint. It's out away from the spine, and you see the openness between the sternal end of the clavicle and the manubrium of the sternum. And you're going to do both sides. Any questions about those? About 10. 70 kV at about 10 mass. Center detector area. And again, this should be marked. Okay. Any questions about sternoclavicular joints? Ribs. Okay. Ribs are confusing when you first start to think of them. For a rib exam, and for the purpose of lab, for a routine rib exam, you're going to have a total of 5 projections for a routine. You're going to have a PA chest. You're going to do a above diaphragm, a PA or AP, depending on your patient's injury, above diaphragm. Then you're going to do a PA or AP, depending on where the patient's injured, below diaphragm. You're going to do an oblique above diaphragm and an oblique below diaphragm. So you've got a PA chest, an AP or PA, and an oblique above diaphragm, so there's 2 and 3, and an AP or PA and an oblique below diaphragm, so there's 4 and 5. So you have 5 total projections within a rib exam. I see Southwest is joined. By chance, can you hear us?
No.
Okay, thank you so much.
Christy, if we go away, we have to take Dawn's test. Christy, stop. Never happens. Dang it. This never happens.
Always an ulterior motive. I know.
We have no idea what you're talking about.
Why are you speaking in Spanish? We can't understand you. There is a connection problem.
Mr. Lowe, are you there?
No, he left the building. He really not.
If I call you when things are going good.
Okay, well, I'm going to continue. until he tells me to hush. We're still in positioning class at the moment. For rib projections, you've got the AP or PA, above diaphragm and below diaphragm, so there's 2 projections. Then you've got the oblique, above diaphragm and oblique below diaphragm, so there's 2 more projections. And you also have a PHS. So that's your routine for a rib exam. Now the oblique ribs are 45-degree obliques. No matter which oblique you do, whether it's an RAO, an LAO, an RPO, or an LPO, they're all 45-degree obliques. And you also determine whether or not you do an RAO, well, an anterior oblique or a posterior oblique based on the patient's injury. So if you did a PA because the patient's injury is anterior, then you also want to do anterior obliques to keep the anterior surface of the body where the injury is closest to the image receptor. And this is confusing, I know. If you do an AP where the patient's injury is on the posterior surface of the body, then you also want to do posterior oblique, because that keeps the posterior surface of the body, keeps the injury closest to the image receptor. Any questions on that? Southwest, when Mr. Lowe gets the link to this class, he will send it to you guys, okay? Okay. Go back to his office, do you know?
You want us to go check?
I'll call him. I think they've got it fixed if you want to take over class. Thanks. Okay, he's on his way. Okay, we will finish this chapter. All we've got left is ribs, but I'll bring Harry and we'll look at Harry, and I'll bring some images. I'll put some images, extra images, and we'll do clicker questions next time. Hopefully, if everybody connects, we'll do clicker questions next time as well. Today is Tuesday. We'll finish this chapter on Thursday. Prepare for a test on chapter 10 next Tuesday. Okay, Mr. Lowe, it's all yours.
Thank you. Did you give him a break, Christy?
Yeah, they had their normal in-between classes.
Okay.
Break.
All right. Okay, very good. Okay, folks, take me just 1 minute here to bring up everything, so just hang tight. Pardon? He's been ostracized for being a bad boy. Those women showing you your place, Steve?
Yeah, you know how it is.
Believe me.
Don't want to be around stick shit.
A man knows his place. That's, behind every good woman, there's a man.
Behind a few words. It's hard to talk about people we know.
Everybody needs a support system, right? Okay, folks, we are going to, that's a definite. You can take that to the bank. We are going to complete screens today. I have no clicker questions either, so Christy, Donna, Jason, I guess attendance. I know everybody's there on the Mountain Empire campus. Withful, everyone present accounted for.
Everyone's here.
Thank you, Jason. And Miss Donna, are you?
We are
Gracie?
100%.
Thank you.
Hello.
Oh, be quiet.
I feel the love.
We don't.
Okay. Let's just get right to it. Well, first of all, I'll ask this. Do any of you have any questions, and especially those of you who were sent the link, do any of you have any questions on information that you reviewed by tape? Okay, I guess that's a good thing, and I would imagine there's at least some of you holding out with questions that you do have, but maybe I'll touch on them as we finish the chapter. It has taken us too long to complete this particular chapter, but we will start with what we finished covering last class period, last Thursday. Asymmetry of screens, and this is, I just wanted to reiterate that when we talk about the asymmetry of screens, remember that you have a cassette. Put you back on me. I'm not sure of what. Okay, I think you're seeing me well enough. Think of the cassette, the film holder, as your textbook. Okay, and if you were to insert a sheet of film or a piece of paper into that textbook and close it, now you've got a light, tight system where that sheet of film, now held in this cassette, is safe from white light. So we would load the cassette in safe light conditions. Now I have I have the safe light conditions built in to chapter 9, and we may get to that today as well. But, you know, I just wanted you to remember that that cassette is like a book. In safe light conditions, that's where you exchange an exposed sheet of film that you take out and process with a fresh sheet of film that you would then insert. That's cassette's now ready for the next exposure, okay, the next projection. So, you know, don't lose the mental imagery of what we're talking about, or you know, some of the statements that I may make won't have as much context. But when we talk about the asymmetry, the front of that cassette, and there is a front and a back, the front of that cassette is going to be of a carbon fiber or bakelite cardboard that's fairly easy to penetrate by the X-rays. We don't want the front of the cassette being a high Z number. Okay? So once the X-ray exposure enters that cassette, it's going to strike the front screen first. Well, the front screen, by its design, is meant to absorb some of that X radiation and produce light. Okay? We don't want it to absorb all of the X radiation because we want a portion of that to also penetrate through the front screen, through the film, and strike the back screen, so that we also have light produced from the back screen. So historically, we're using a two-sided film, a double emulsion film. Okay, one on one side of the base, the other on the other side of the base, the emulsions. Okay, and we want both of them to get an equalized amount of light. Okay. Remember, X-rays can travel through, so we're not so much worried about the two sides being exposed to the direct action of X-rays. But we want both sides getting equal amounts of light. So, the front screen is thinner and has a lower DQE. The back screen is thicker, so that the remaining X-ray, the phosphors there have a higher DQE possible, okay, because we want as much light emitted on that side of the film. Now, it doesn't seem like a big thing, especially when you keep in mind, you know, this sheet of film is no more than a few micrometers thick. It's very thin. 2 or 3 sheets of paper, you know, of your notebook paper would be the equivalent thing. But that is the asymmetry of the screens. And then we talked about this slide, you know, if we allow the darker blue line to be the total response, the front screen would be the green line, and the lighter blue line would be the back screen. And you can see that they would both, in part, add to the density produced on the radio. Not a big. Screen film contact we talked about, that's ideal. You know, we want the two sets of screens to sandwich that sheet of film between them evenly. But due to damage to the cassette or possibly damage to the screen itself, sometimes we get, you know, this was the only way that I can demonstrate. You get separation. And when you get separation between the screen and the film, light doesn't travel very far. Okay? So we get a reduced effect of light reaching the film. So when we do the wire mesh test for film screen contact, if we have a bad cassette or a bad screen, what you would see is the image on your right. Okay? The image on your left is pristine, but the image on your right shows some film screen contact. Okay? Now, I know that sounds insignificant, but please remember that the wire mesh test instrument or test tool is used for evaluating screen film contact. Excellent test question, excellent registry question. And then I showed you the examples. These are both examples of where the cassette, they have locks, they have hinges on one side, they have locks on the other to hold it shut. This is an example where maybe there's been a damaged cassette where the locks frequently pop open. Okay, so as a department administrator, you'd want to get these cassettes out of use, because not only does it run radiograph, it increases patient exposure. Why? You're going to have to repeat. Yeah. Anytime you're doing a repeat, for whatever reason you're doing a repeat, you're increasing patient exposure. So get these out of service as soon as they're identified so that you're not repeating patient exposure. But what you're seeing here, these real black areas, is where white light rushed in and totally exposed that sheet of film. So when it's processed, it shows up jet black. That's maximum density that can result on that film. The one on the left here of the vertebra, it's a blow up of a cassette of an image resulting radiograph actually, and you can see this white speck. That was an artifact. What is it? I don't know. It could be a piece of lint, could be a piece of paper. It could be a lot of things, but it actually even could be a piece of metal in the patient's skin. Okay? We can't look at this and determine what caused that artifact. But what we would do is, if we had the full image of this cassette, we number our cassettes in the department with a black magic marker. Okay, now keep in mind, if you write in that cassette with a black magic marker, that number is going to show up on every radiograph that you produce using that cassette. So if you put a number on the inside on the screen and you put a number on the outside identifying the cassette, you can go back and find this cassette, take it in, and clean the screens to see if that gets rid of this artifact. Okay. The image on the right here shows poor screen film contact, especially right in the middle of the thoracic spine area here. And, like I told you the other day, you need to look at this on your own PC, because the areas down here in the upper lumbar are nice and clear, and they get clearer up here in the upper thoracic. Right here in the mid thoracic, it is unsharp, and that's what poor screen film contact would look like. Okay, to the naked eye. Okay. You're not always going to be able to see it, but in some cases you may. Here we have two examples. You can see the radiograph on the left over the kidneys. Okay, but you see all those little specks, and you might say, quantum model. And if you did, I'd probably pat you on the back, because that's what quantum model does look like. But in this case, this is phosphors that have been damaged because of cleaning with improper solution. Okay. These are dead phosphors, so to speak. And so where we see the splotchy areas is where that phosphor is not allowed to give off any light, and so you get white specks instead. The image on the right here is the same screen, but without an anatomy part taken during the exposure. So, you know, how would you tell quantum model and dead phosphorus apart? Probably couldn't. Okay? They resemble each other. So you'd have to know some of the history of the cassette to determine this. This was when I was the director at the Johnson Memorial. And, you know, we say that we number every cassette. This cassette was numbered. We identified that there was some dead phosphorus. It took us forever to chase this cassette down because it was a 10 to 12. We had so many 10 to 12s, and it would get moved from room 4 to go to a portable. And then it would come back and end up in room 3 because that's where somebody stuck it back. We finally did find it. We took it out. So, care of screens. You know, you don't want to leave the cassette laying open. Okay, you want to take the exposed film out and refill the cassette with a fresh sheet of film and close it. Okay, because damage potential always exists. Causing artifacts always exists. It might be a hair fall out of your scalp. It might be a piece of paper that, you know, when you lay down a cassette beside the open cassette, that small speck of paper floats over and gets in. So, you know, we periodically want to clean cassettes. A real mild soap and a non-abrasive cloth is the best way to clean your screens. Now, you can use 70% alcohol. Some people discourage it, but 70% alcohol is not going to cause phosphor damage. So, again, with a non-abrasive cloth. Screens don't burn out. And they emit light. These phosphors that are in screens, they don't lose their ability to give off light even after 20 or 30 years, unless we damage them in some way with improper chemicals. When we clean screens, we do set them up on edge. I demonstrated that last week, and let them dry, because you don't want a moist screen and then put a sheet of film in there and close the cassette. Why? It will soften the emulsion, and then it sticks together, and you do more damage when you open the cassette to the screen than you can repair. So then you have to replace it. Okay. So be careful not to put magic marker marks. You know, if you're trying to dig a sheet of film out of the cassette and you have a magic marker in your hand where you're going to write something on a flashcard to identify that sheet of film, you know, if you make a little ink mark inside the cassette, it's an artifact. It shows up on every readygraph until you remove that artifact. Certainly, you don't want to throw these things around. Yeah, they're pretty durable, but number one, a heavy jolt can cause static that's going to fog the film. Okay, that's the least important damage that you might do, because that's one sheet of film. But if you break the cassette frame, or if you warp the cassette frame by abuse, okay, then it creates poor screen film contact, light leaks, results in loss of spatial resolution. So, you know, that's when, if we question that that has occurred, that's when we do the wire mesh test. Okay. Let's sum this chapter up. We have screens. The screen's purpose is to accentuate the effect that exposure has, X-ray exposure has, on the film, okay, by absorbing more of the X radiation with screens that then produce light to also assist in exposure of that film. Okay, it's the purpose of screens. What terminology do we want to remember? We want to remember DQE. Okay, it is the detective quantum efficiency of those phosphors that are embedded in the screen. Okay, in the phosphor layer, the active layer. What's the DQE? The ability to absorb X radiation. Okay. Remember that the energy of the photon, KVP, plays a part of the DQE. But the DQE is actually the property of the phosphor. High atomic number phosphors do a better job of absorbing the X radiation. Now, once absorbed, we want to remember the term conversion efficiency. The first two letters out of either word, CE, means the ability for that phosphor, once it absorbs X-ray energy, to give off light. These affect the speed of the screen, the DQE, and the conversion efficiency. Conversion efficiency of the phosphor you cannot change for a particular phosphor, but the DQE you could change. If you make the phosphor crystal larger, if you make the phosphor layer thicker, if you have more concentration of phosphors within the active layer, all of those are going to increase the DQE, which in turn increases the speed of that cassette, of those screens. Okay. And if you're increasing speed, you could reduce patient exposure, because then you can reduce the necessary exposure to produce the same density. It will also affect spatial resolution, which is the next slide. So remember the speed and those things that control speed. And when we're talking about speed, the opposite effect of speed is what's going to occur to the spatial resolution. Okay? And remember down here at the bottom, without reading the entire thing, what happens is when we use a larger crystal or a thicker phosphor layer or a higher concentration, we make it faster. We make the screen faster. But we lose spatial resolution, lesser detail. Okay? Conversely, if we have a smaller crystal, smaller phosphor, if we have a thinner phosphor layer, it makes the speed slower, but we get better spatial resolution. So a department might have detailed cassettes and then high-speed cassettes. You would know that detailed cassettes are for extremity use, okay? Because that's where you're going to actually be able to demonstrate higher spatial